Good morning. Thank you for inviting me. Do any of you know who Professor Mervyn Singer is? No? Oh. This is the first intensive care meeting I've been to in 15 years where Mervyn hasn't been here, so I feel very privileged to be asked. So today we're going to talk about roles and limitations of fluid loading. And this is the objectives. In English, to know the latest evidence on available fluids and risk related to fluid balance. These are my disclosures, none of which are relevant to this particular talk. This is a very fine example of French engineering and of balance across fluid. I'm sure some of you recognise this. Yeah, it's where I go for my holidays in the summer, on the Ile de Ré. So it's one of my favourite spots in France. So, fluids. So some of us probably think the same as the thinker here. What harm can they cause? They're very useful, mainstay of our treatment. Some of us may think that fluids are dangerous. So, which one are you? The thinker or the monkey? Okay, for me, I'm the monkey, but still, that's. So, what do we view, or what do I view as successful fluid balance? Okay, in our what we call in the UK level 3 patients, full ICU patients. Well, we want to try and minimise our organ support and interventions, if possible. We want to try and minimise days of ventilatory support, need for pressor support, perhaps stop people getting AKI. Try and do it cheaply, and hopefully our patients will also survive. This is the thing the doctors want. The one above is the thing the managers want, of course. So with fluid balance, we don't want this, okay? Or this. We want this. And this is Goldilocks and 3 bears. So each bear has the right amount of porridge or the right amount of fluid. And this was quite nicely portrayed by John Kellum, where he just did this schematic diagram between complications over time related to volume of fluid. So, with too little of fluid, we may be at risk of organ ischemia. Too much, risk of organ edema, just right, or hopefully the patient does very well. So what happens when we give fluid? This is an incredibly simple or simplification of what actually happens when we give fluid, but for some of my colleagues I think they still find it too difficult to understand. So when we give fluid initially, of course in some of our patients they just have a huge inflammatory response and just have a capillary leak syndrome and nothing seems to happen at all. In other patients there's a rise in venous pressure which can lead to an improvement in preload and preload responsiveness, improvement in cardiac output, blood pressure, effect on kidneys, etc., etc. So that's one way of looking at it. Rather simplistically, because when I started intensive care medicine when I was the age of some of the people in the room, all my practice was aimed at making the intensive care patient look like a normal patient. But as I get older, I think perhaps that's not the right thing to do, but that's a subject for another lecture. Oop. So, this is what some of my colleagues think. If I give fluid, the venous pressure goes up, blood pressure goes up, there's better urine output, maybe, so there must be some fluid responsiveness, so that's good for my acute patient. In all cases, I don't know. This is quite an early paper, 1992, and it just compared patients using pulmonary artery catheterization to 2 fluid strategies. You rarely see this paper quoted now, but there are 101 patients, post-surgical, I think, randomized to 2 fluid management strategies, one based on the pulmonary artery occlusion pressure, and the other based on a lung water algorithm. It's one of the first and not particularly accurate, but effectively what they showed was that the wedge pressure group got more fluid. And what did that translate to? It translated to the patients who got less fluid, having less days on mechanical ventilation and less days in the ITU. So over 20 years ago, when I could see without glasses and have my own hair, over 20 years ago, we knew that a positive fluid balance was a bad thing in our intensive care patients. This is another paper that you quite often see quoted, nearly 10 years old, 9 years old now, which showed that positive fluid balance, 24, 48, 72 hours, are all associated with weaning failure from mechanical ventilation. And the ARDSNet studies, as you've I'm sure all read, have taken that even further with their rather impressive protocol. I don't expect you to read this, but the one thing of note, and I'll just point out here, is the liberal strategy. You allow the venous pressure, central venous pressure of over 18. So really quite an impressive high right-sided pressures. What did that show? It showed the higher filling pressures, or the less liberal, or the liberal group did worse. All right? They had a longer time ventilated and longer time in hospital. I keep pressing on. So conservative fluid strategy shortens the need for ventilatory support. And that's shown here quite nicely. But what about the kidneys? Okay, what about the kidneys? They might not like that. Kidneys like fluid, so no fluid they might not like. They need fluid, don't like being dry. Cosmopolitan, which is a magazine in the UK, probably all over the world actually, tells me I must drink about 2 to 3 litres a day, and you can do better in your exams if you drink more water, apparently. Because this was a blonde woman, I was going to make some mention about Hollande, but I thought I probably wouldn't. But it's interesting because the UK normally sees the royal family being on all the tabloids. It's interesting to see French politicians all over the English tabloids, but still. So, if we look at the ARDSNet data, what did that tell us? Well, it told us that the dry patients really didn't do much worse. The incidence of renal failure was about the same, and in fact, there was no difference even in the need for dialysis. Now, Didier Payen, who's one of your great leaders in French intensive care, looked at a retrospective analysis on the SOAP study, and he also showed that a positive fluid balance is associated with a worse outcome in patients with acute renal failure, as it was called then. It was this prospective, multi-centred observational study, and there we showed that if you developed acute kidney injury, or more likely to develop acute kidney injury with a positive fluid balance, and patients with acute renal failure did worse than those without acute renal failure, not surprisingly. Also, patients who still passed urine did better, and clearly patients on renal replacement therapy did worse. The problem is that chicken or egg situation. And Didier himself outlined this, saying it isn't possible to determine whether the positive fluid balance found in these patients is the cause or the result of the severity of illness, especially as the resuscitation protocols weren't standardised. So it wasn't standardised treatment throughout. There have been more studies that have highlighted the problems with positive fluid balance and acute kidney injury. This is subset analysis from the Picard study, and again showed an adjusted odds ratio for death with a positive fluid balance. So fluid overload seems to be bad in ARDS and acute lung injury. It's bad in acute kidney injury. What about our patients actually commence renal replacement therapy? So if they have a positive fluid balance, but we put them on renal replacement therapy and see what happens. Well, the FORNI study, which is giving us quite a lot of interesting data, again shows that critically ill patients with renal replacement therapy, if they're fluid overloaded, they do less well. Okay? And this was at the time of going on to renal replacement therapy. So patients with fluid overload, greater than 10% of their dry weight at initiation, had a higher crude mortality. So, what about sepsis? We know the top three. What about sepsis? Well, again, unsurprisingly, a positive fluid balance and elevated CVP are associated with an increased mortality. And this is a study from the VAST group, or the VAST study, and again showed the drier the patients are, the better they do. This one we all know, this was quite a surprise, I think, when this came out. It was released just before one of the UK equivalent of the SRLF, and it became one of the main talking points of the meeting. This study from Africa with children with severe malaria, which again showed that volume boluses, the patients, in this case the children, did less well. This has just come out this week, on Tuesday, I think. Again, Didier PM was involved and Mathieu Legrand, and it's an association retrospective study on systemic hemodynamics and septic acute kidney injury in the critically ill, again looking at various parameters. This was the cohort diagram. One of the things I found quite surprising, and it may be a reflection on the difference between UK and French ICU practice, I'm not sure, but half of the patients that were defined as severe sepsis didn't have a CVP or any cardiac monitoring of it in the first 24 hours. So they were excluded. But I do find that quite a stunning statistic. I'm not saying we get it right in the UK, but to get into our ITU, invariably you would have to have some form of central monitoring. Anyway, what did it show? Well, it seemed to suggest that at venous pressures higher than 12, there was an increased risk from mortality in patients with acute kidney injury. And that, of course, 12 is fairly conservative when you consider the ARDSNet study. They also looked at transient or persistent acute kidney injury, one of my favourite topics, and showed that people with persistent injury did less well. Of course, it's not always straightforward, and one can always find studies where there is no association between fluid balance and outcome. And critical care need to be applauded, really, because it's quite difficult to get negative studies published, but I think it's quite important. So why is fluid overload so bad for you? Well, this is a schematic diagram I borrowed from John Proud, a good friend of mine. So this is our patient with fluid overload. These are the problems that they experience. Cerebral edema, we all see that on our patients, particularly in terms of delirium when mixed with their drugs. Problems with gas exchange, myocardial edema, liver's never happy, tissue particularly unhappy, and our nurses spend a lot of the time keeping care of our patient's skin, gut edema, and importantly, from my point of view, increased renal venous pressure and increased renal and interstitial edema leads to reduced GFR. So the mechanisms of that, well, we know intra-abdominal hypertension is associated with positive fluid balance and acute kidney injury, probably because of its effect on glomerular hemodynamics. Venous congestion in heart failure is also associated with positive fluid balance and acute kidney injury. We know if we can turn around the fluid balance in some of these acute patients, they do better chronically. In the acutes, it's a bit more difficult. Also, oxygen delivery and hemodynamics is not a direct relationship, and in our patients particularly it's complex. And volume resuscitation in sepsis isn't really related to tissue oxygenation. We know that. So the blood may spin round, but it's not being utilised. So to conclude, from my point of view, patients in ITU need some fluid, but there's really little evidence to say how much per kilo, and I think the idea is we resuscitate and then reassess. It's very easy to give too much fluid. Quite often it's inevitable. I think you should, in our population, use some form of hemodynamic monitoring. You should try and repeat or resist repeated fluid challenges, which my juniors do based on capillary refill or a bit of urine. They're never quite sure. So I try and resist that. And perhaps consider early renal replacement therapy to prevent fluid overload. And I think we may see more of that in the near future. And certainly better data is needed to guide our fluid resuscitation, particularly in sepsis. So, the take-home message really, fluid overload in our ITU patients is strongly associated with harm. And with that, I'd like to thank you for your attention.